My name's Chad Hockey. Thank you very much for inviting me today. I work as a GP. I've been asked to speak more loudly. Okay, I work as a GP in London, and I'm a clinical director of a primary care network as well, otherwise known as a PCN. I think my section was to talk about primary care, and I think it's important to make that distinction between general practice and primary care. So general practice is not primary care, it is part of primary care. Primary care, as you've been hearing from the other speakers here, is everything that takes place within a community. It's not just the services, it's all the things that keep people well. And so that's what I want to talk about now, because I don't think we can talk about healthier places and fairer systems without actually talking about systems. We've had in medicine for a number of decades now an approach of evidence-based medicine. We do things based upon evidence, we do studies, and we try and make changes based on evidence. But we've had 4 decades of reports telling us that we don't have fair systems, that we don't have healthier populations, and we're not making changes. So this has to be a conversation about change, how we can do things differently as a system, so that the next report in 10 years' time isn't the same as the one that we've just had. So it's worth just reflecting a little bit about why we're having this conversation, what systems are doing at the moment that's creating the kind of narrative that we're seeing. In my PCN, about 11% of the population, of the adult population, have diabetes, or they're pre-diabetic. They progress to have complications more quickly, vascular problems where they'll end up needing the care of vascular surgeons. 2 miles away in the same borough, that number's about 6%. That hasn't happened because these people have chosen to become diabetic. It's happened because of the circumstances of their lives, make it much, much harder for them to be healthy. This is stuff that we create as systems. So the very first step, if we're thinking about having a healthy system, is to own the problem. We build this ourselves, which means that we have to own it, really, really own it, not just about numbers, not just about having a graph or in an abstract sense. It has to matter to the people that are rebuilding the system deep down inside them, in the same way as you've been hearing from the narratives of people speaking this morning. It matters to people. And there are ways that we can help people do that. I'm so lucky as a GP. I'm privileged because I get to hear people's stories every single day. Whereas the people that are building systems, the people that are redesigning systems don't have that privilege. So we can help them to understand the narratives of people's lives. The second step is to understand the causation. So we can't change the macroeconomics that give people different opportunities in their lives. That's beyond our control. We're not going to change that. But we can change the things that create uneven distribution of risk. So people have an uneven distribution of opportunity, but actually that exposes them to different levels of risk. We've seen that with COVID. People that had to go by public transport, they were on 0-hours contracts, they were living in cramped accommodation. You've heard it from other speakers here this morning. And that then leads to the downstream consequences of different prevalence of illness. So illness and wellness aren't the same. And we've, as a system, historically have focused on provision of services. So everything is about downstream management of illness through a service. And that creates a power dynamic. So you have a service, it means that you are a service user. Somebody is providing to you or for you, not co-production, as you've been hearing. And that's the thing that leads to inverse care, because to have a service, you need to have a service provider. You then have to have funding for that provider. And if the workforce isn't distributed evenly, you then end up with uneven care provision. But again, as you've been hearing this morning, service is just one part of the equation. There's so much going on in the community. As we're surrounded by people with phenomenal assets, there's so much happening within civic activity. These bits need to be brought into the equation as part of the thing which fixes to create healthier places. And then the third step I've put down here, power hungry animals. I think there's a song for everything, and that's the song for this bit. It's people that change systems. It's not going to happen on its own. And there are all sorts of ways that we can empower people, educate people, connect people in order to create fairer systems. So you'll probably hear a bit later on about health equity leads. There are ways that systems, rather than commissioning, could actually employ people to build the connections between the civic and the community and the service type partnerships. So we need to understand this as a system if we're going to change it. And I think meetings like this one that you're having this morning are so important. And it's so important we recognize that we all have a part to play through our connections and our networks. Every single one of us can influence somebody around us to do something that's different. Thank you.